All right, starting webinar. Okay, we'll just give a few more minutes to allow people to get into the webinar before we start. Welcome, everyone. Wonderful to see so many people from all over the U.S. Yes, please feel free to use the webinar chat and let us know where you're from if you're comfortable sharing. And we'll start in just one more minute. All right, so why don't we go ahead and get started?
Okay. Well, good afternoon and good morning, or some, I guess, I'm not sure, but hello and welcome everyone to the BWHS seminar on healthy aging. It's so nice to see and hear everyone again, and thank you for all of your greetings. Next slide. So just a little bit of housekeeping, how you can ask questions during this webinar. You'll see that there's a Q&A button at the bottom of the screen. The chat on Zoom would not be the best way to ask questions because there's so many greetings and things coming in, we won't see it there. So please use the Q&A for questions. You can also post questions in the chat log on YouTube. or you can email us directly during this webinar at bwhs@bu.edu. Next slide, please. There's also closed captioning available for those that need that. You can activate that using the live transcript and then select show subtitle. And again, if you're viewing us through YouTube, you can click the CC or closed caption icon at the bottom of your screen. Okay, next slide. So I just want to give a very brief overview of the BWHS. Most of you are familiar. There may be some joining us who are not direct participants of the cohort. So we began this journey in 1995 when 59,000 of you brave women completed the questionnaire that we'd mailed out. We've been following up with you every 2 years since, as well as with annual newsletters. And when we began this journey, the median age of participants was 38. It's now 65. So we've all been here for a while now, a little minute, right? So we're going to talk today about aging and how we can be better at it. Next slide, please. Back in 2020 and 2021, we had a series of webinars, one at the end of 2020 to mark our 25th anniversary. And then in 2021, we had two, one looking at the COVID-19 epidemic, and then later in spring of 2021, talking about at the time what our future plans were. If you didn't get to see these or you'd like to see them again, they are available on our website at www.bu.edu/BWHS, and they can be viewed there. Next slide, please. So I should introduce myself. My name is Yvette Cozier. I'm one of the investigators in the Black Women's Health Study. And today I'm going to be joined by my colleagues, Dr. Lynn Rosenberg, Dr. Patricia Coogan, Dr. Shan Sheehy, and Linda Villarosa. And we are going to talk about a few things. One, about our minds, talk about some research that's ongoing on insomnia and cognitive function, our body, about the role of physical activity in keeping us healthy, and soul, about religion and spirituality, how that works to keep our health at top. Also, we will hear from Linda Villarosa about her book, Under the Skin, and then we will have time for questions. So let's get started, and I'd like to introduce Dr. Lynn Rosenberg.
Thank you. So over the years, we had comments and questions that BWHS participants sent in saying, I have sleep problems. What's the story here? So we looked into it, and we found something called the Insomnia Severity Index, which is 7 questions about difficulty falling asleep. And we put this on the 2015 questionnaire. 30,000 participants completed it, and 15% of them had scores of 15 or more, which is indicates that they had insomnia. And this compares to about 10% that you would see in white women. Next slide, please. So we looked into treatments for insomnia, and there is patient education. You can get this material at your doctor's office probably. And it has a low success rate in curing insomnia, but it's pretty good at lessening some of the symptoms of insomnia. It's good to know about good sleep practices. You can be given drugs, but they lose their effect after long durations of use, and they don't work that well. The best treatment is something called cognitive behavioral therapy for insomnia, CBTI. The problem is there are very few practitioners trained in this. Next slide, please. So when we looked into it, we found that there's a treatment that can be completed over the internet, but you have to be part of a randomized trial. It's called Shut-Eye, Sleep Healthy Using the Internet. And it consists of 6 modules. You log in every week or so and work through one of the modules. I did that, and all the people on the study did, and it actually works very well. It's been used in many randomized trials, but with very few Black participants, and they were less likely to complete the program. So we said to ourselves and to the funders, let's test Shut-Eye, but let's make a new form of it called Shut-Eye BWHS, where all the visual content will be adapted so that it's more relevant to Black men and women, because it has stories about Black men and women, and would have advice from Black experts. Next slide, please. So this shows a comparison of the Shut-Eye and Shut-Eye BWHS. In Shut-Eye, here's Dr. Ritterband, an expert on sleep, a white man giving advice. And in the revised Shut-Eye BWHS, here is Dr. Clark, who is a sleep medicine specialist giving advice. Next slide, please. So we contacted people who had completed the 2015 questionnaire with scores indicating insomnia, and invited people to be in the trial and randomized them to either Shut-Eye BWHS, Shut-Eye, or patient education. And at time one, they completed the ISI questionnaires and then started with their treatments. 9 weeks later, the treatment period was over and they completed more questionnaires. And at time 3, 6 months later, they once again completed the ISI. Next slide, please. So this slide shows that at time 1, these are scores on the Insomnia Severity Index, where 15 or greater means that you have insomnia. So you can see everyone had insomnia or even more severe symptoms. At time 3, 6 months after the treatment began, you can see that people in Shut-Eye BWHS, the blue, or Shut-Eye, the orange, had much better scores than the people in patient education. So many of these people no longer had insomnia. It was very successful. Next slide. So the question is, where can you get this kind of treatment? Well, you can try to get it by going to your physician or the practice that he's part of or she's part of, and see if there's someone who can administer CBTI to you. There is online treatment called Somnolist, which is identical to Shut-Eye. And to use this, you would have to get your practitioner to write a prescription for you. So unfortunately, as you can see, these very good treatments are not universally available across the US, but we're working to see if we can get people in charge to get busy trying to get these treatments available. Thank you. Oh, and that slide just shows where you can get some very useful information on good sleep practices, and that they are very, very helpful.
Thank you, Dr. Rosenberg. Next, we'll hear from Dr. Patricia Coogan.
Thank you. Today I want to tell you about a study that we published on experiences of racism and cognitive function. In the study, we've been thinking about and planning to study cognition in the cohort for a long time because the cohort's aging. As Yvette mentioned, half of the participants are over age 65. And as people age, cognitive decline happens and the risk of dementia increases. Next slide, please. So it is of particular importance to study cognitive decline in African Americans because the prevalence of Alzheimer's disease and dementia is higher among African Americans in the United States than all other racial groups. So this chart shows that. It shows the proportion of people in these various 3 age groups that have dementia among blacks and whites. And so 2 things to notice. The proportion is higher among African Americans at each of these 3 age groups. And then just look at how high the prevalences are, up to 43% of African Americans age 85 and older. And we know more and more people are living to be these older ages. So the question is why? Why is the rate higher? What about the life experiences of African Americans could contribute to this? So what comes to top of mind is experiences of racism. They are a chronic stressor for African Americans. We know that stress affects cognition. Experiences of racism have been linked to physical and mental ailments. There's less known about its effect on actual cognition. And by cognition, I mean the actual mechanics of thinking, memory, problem solving, ability to make judgments. So we can look at this question in the Black Women's Health Study because we asked about both. Next slide, please. So these questions will no doubt look familiar to you. This is how we assess your experiences of this, what we call daily racism, these incidents and situations that happen in everyday life. And the choices range from never to almost every day. And for analysis, we sum these up into a score and divide it into 4 categories ranging from very low experiences of racism to the highest. Next slide. Now, subjective cognitive function. So this refers to how you, the participant, experience your own cognition. So in 2015, you may remember this list of 6 yes/no questions asking about certain aspects of cognition. And it ranges from things that are just kind of normal consequences of aging, like, not really remembering some things very well, to the things that are not normal parts of aging. They're like losing your way around familiar streets. That is not a normal part of aging. That's a symptom of pathology. Next slide. So we took the answers to those 6 questions and simply added them up and divided them into 3 categories of good cognition, which is people who didn't answer yes to any of them. And as you can see, 60% of the women, and this is women age 55 and older, had none, rate down to poor. And this is women who answered yes to at least 3 of those questions. So with these 2 bits of data, we tested our hypothesis, which was that women at the highest levels of the racism score would be more likely to report poor cognition than women at the lowest level. Next slide. And these are the results which bear out the hypothesis. These bars show that in the yellow bar, which shows women at the highest level of the daily racism score, have over 4 times the risk of scoring as having poor cognition compared to women in that lowest level of racism score. So this is a strong association. Next slide. So I want to end by saying we have just recently received funding to study a hypothesis dealing with structural racism. Does structural racism affect dementia incidence? And by structural racism, I'm referring to sort of the policies and regulations and rules in the United States that have fostered and maintained racial discrimination over the years, like redlining and mortgage lending, segregated neighborhoods, and so forth. We've just started this. We're just in the first few months of this study. And next slide. My final slide just shows a resource with suggestions for how to maintain brain health at NIA, which is the National Institute of Aging. Thank you.
Thank you, Dr. Coogan. Next, we'll hear from Dr. Shanshan Sheehy.
Good afternoon, everyone. It is my great pleasure to present our study on leisure time physical activity in relation to mortality among African American women. The physical activity guidelines for Americans lay out how much physical activity we need to get health benefit. According to the guideline, physical activity can help prevent disease, disability, and premature death. Physical activity virtually benefits everyone, men or women of all race and ethnicities. However, according to national data in 2020, 32% Black Americans engage in no physical activity in their free time. To address this issue, U.S. Department of Health and Human Services set up national goals for Healthy People 2030. One of the main objectives is to improve health, fitness, and quality of life through regular physical activity and reduce the proportion of adults who do no physical activity in their free time. As you may remember that in our BWHS questionnaires, you fill out questions like this. During the past year, how many hours each week did you spend on average walking for exercise or doing vigorous exercise such as jogging? The physical activity information was collected at 8 questionnaires across 25 years of follow-up. And thank you to you, our wonderful participants. Majority of women responded to these questionnaires, and thus allow us to examine the long-term impact of physical activity in relation to mortality. Specifically in this study, we found that walking for exercise was associated with lower mortality. Compared to no walking for exercise at all, those women who work for more than 5 hours per week have the greatest benefit and have a 31% lower mortality. Even for women who work for less than 1 hour per week, which is lower than the guideline recommended level, we can still see a 17% lower mortality. Similarly, for vigorous exercise was associated with lower mortality. The more active you are, the lower the mortality. Performing vigorous exercise for an hour or so a week may be a more attainable goal, and we can still see a 26% lower mortality. In summary, our study provides encouraging evidence that a small amount of physical activity can still make a difference for Black women. Every step counts. Even small amount of physical activity, less than guideline recommended levels, are still beneficial. Thank you.
Thank you, Dr. Sheehy. And so now I'm going to talk about 3 studies that we've conducted within the Black Women's Health Study on religion and spirituality. And the question we wanted to know is whether or not religious practice and involvement in spirituality could impact health. These 3 studies answer a slightly different question, but I'll go through each of them. Next slide, please. So again, what motivated us to study this was that there's a growing body of research showing that various forms of religious and spirituality practice was related to some health outcomes, particularly better health. And there's a reason that could be because religion and spirituality can shape our individual beliefs and behaviors. It provides community and social support and even a sense of meaning in life. And that even recent research has shown having a meaning and a reason for getting up every day is a determinant of greater health. Also, a national survey of American life in the mid-2000s found that Black survey respondents were more likely than white survey respondents to indicate that religion was an important part of their daily lives, meaning they brought this into every aspect of their daily life. Also, other research has shown that Black patients would be more likely than white patients to rely on their faith to cope with stress and particularly serious illness. Next slide, please. So starting in 2005, we began asking questions about religiosity and spirituality. These 4 questions in particular: how often women attend religious services, how often we pray, to what extent do you use your religion or spirituality in coping or understanding and dealing with stressful situations, and to what extent do you consider yourself a religious or spiritual person? Next slide, please. We also, a few years afterwards, sent out a more detailed 4-page supplemental survey to a handful of, or I would say a handful, for a couple of thousand of BWHS participants. This did not go to the entire cohort. But what we were trying to do was get a deeper dive into understanding all of the dimensions of religion and spirituality and how they played out in women's lives. Next slide, please. That same survey was also sent to a sample of participants in other health studies involving women. So the Nurses' Health Study, which is predominantly white women, answered that supplemental questionnaire. The study of Latinos, mostly or entirely Hispanic cohort, the Strong Heart study of Native Americans, and the Masala study of Southeast Asians. So along with the Black Women's Health Study, these 4 other cohorts answered those questions. And on this slide, I'm showing how Black Women's Health Study participants compared to the responses from these other cohorts according to race. Next slide, please. We can see for a few of these items, particularly considering oneself to be very religious or spiritual, church attendance, meditating daily, using religion and spirituality in coping or dealing with stressful situations, and believing that God provides the strength to do what otherwise would not be able to be accomplished, that African-American women, Black women, in particular members of the Black Women's Health Study, scored higher than any of the other cohorts in those areas. Next slide, please. We also asked, based on the BWHS main questionnaire, about church attendance, and did an analysis comparing this with mortality. So what we see is for the women who attend church most often, their risk or rate of mortality was lower than those who never attended church, for example, or those who attended church less frequently. Next slide, please. We also looked at using one's religion or spirituality as a mechanism for coping. And in relation to hypertension, those women for which religion and spirituality was, very involved in coping with stress, we see that their risk of developing hypertension is lowest compared to those who either did not involve religiosity and spirituality, or those who only involved it moderately. Next slide, please. So to summarize, there seems to be a benefit of engaging in religious and spirituality practices, a benefit for health, but we have to caution that this is a very complex variable, and that the relationship with health can also be a bit of a paradox. So thinking about, how often, we looked at another question of how often you prayed and mortality. And for those who prayed the most, mortality could be highest. This has also to do with that, coping with illness when one is very sick, and being closer to a mortal event could lead to increased prayer. Also with church attendance and hypertension, a different question that we asked. And, we found that those who didn't attend church very often actually had slightly lower risk of hypertension than those who attended at a more frequent basis. So again, these can present paradoxes, and it's something that we need to tease out in further analyses. Next steps is that we want to see to what extent does religiosity and spirituality buffer the effects of life trauma? And might this be something that contributes to longevity? So next slide, please. So at this time, it is my great pleasure to introduce you to Linda Villarosa. Linda Villarosa is a journalist, an educator, and a contributing writer to the New York Times Magazine. She covers the intersection of race, justice, and public health. She is a former executive editor at Essence Magazine and her essay on medical myths was included in the Pulitzer Prize-winning 1619 Project. Her 2018 New York Times Magazine article, Why America's Black Mothers and Babies Are in a Life or Death Crisis, was a finalist for the National Magazine Award. Linda is a professor at the Craig Newmark School of Journalism at the City University of New York, with a joint appointment at the City College of New York. Most importantly, Ms. Villarosa was a founding member of the BWHS Advisory Board in 1995 and is a BWHS participant. Her book, Under the Skin, The Hidden Toll of Racism on American Lives and the Health of Our Nation, was published in June 2022. It's my pleasure to turn this over to Linda Villarosa. Thank you, Linda, for being here.
Thank you. I am so excited to be here. And I wanted to, I'm so impressed with this study and wanted to give a little bit more about my history with it. I was the health editor of Essence magazine. And I think Doctors Rosenberg and Palmer came to me and were, trying to get people to enroll in it. And were sort of like worried if they'd have enough Black women. And so I did a story on the research because it was really important to me. I had been a health communications fellow at Harvard. I learned about the nurses' health study, and I'm like, why are there so few Black women in the nurses' health study, given how many of us are nurses? And it didn't make sense. So when I heard about Black Women's Health Study, I was really excited, did the story in Essence, and signed up for it myself. And I've been a participant ever since. And I think the other thing that happened was really early on, before a lot of other, even the health organizations, figured out the toll of racism on people's lives. Y'all really put that in early. It was much earlier than other studies for sure, but also even other health agencies and organizations. So I was very impressed with the way the effect of race and racism on our bodies mattered. I'm just going to talk a tiny bit about my book and how it came about and what it's about. And usually when I do a story, I start with a number or something that makes me really, really angry. And I think the underpinning of this book is that America is the richest country in the world. We have the most advanced health care of any country in the world. We spend more on health care than any country in the world, $12,000 per person per year. Yet we don't have good health as a country. So we have the highest rate of infant mortality among the wealthy nations. We have the lowest life expectancy. And then everything else in between is pretty bad too. And also when you look at maternal mortality, we're the wealthy country where our rate is going up and where our rate is higher than every other wealthy country. And when you ask this question of sort of why doesn't money buy health in this country, you get this sort of question mark, sort of like, oh, I don't know. It's so confusing. It's strange. And it's not really strange at all. The main reason is that we don't have healthcare for all. We don't have universal healthcare. So that leaves many people left out. But even if we did, every single person was covered. Healthcare is not the only reason why Black people as a group lack good health, lack this equal health outcomes. Our health outcomes compared to white people have never been the same, have always been worse. And part of it is simply because of racism in our country and in the healthcare system itself. And I think that this really, really hit home for me in 2017 when I heard the statistics around maternal mortality. And I love that, discussion of physical activity because I'm really high on the physical activity scale. I play recreational soccer with an all genders, all ages group on the weekends. And one of the people in my group worked for the Center for Reproductive Rights. And she said to me on the soccer field, she said, did you know all these statistics about maternal mortality? And I was thinking to myself, well, I'm sure it's a question of it's only the poorest people without access to healthcare are dying related to having a baby. And then she said, did you know Black women are 3 to 4 times more likely to die or almost die related to pregnancy, childbirth, and the few months after? And I said, no, I didn't know that. and that sounds bad, but again, I'm thinking it's only in the deepest pockets and the worst places in America where people are really left out, which is terrible, but it didn't kind of rise to the occasion of an article. It was something that I thought everyone already knew. And then she pulled my little jersey and said, no, listen to me. A Black woman with a master's degree, a JD, an MD, or a PhD is more likely to lose her life or almost die related to pregnancy and childbirth than a white woman with an 8th grade education. And that is when I paused and started really listening to her. Now that I know those statistics and I've looked at, I've really studied this, I can see that what's very strange is the problem is worse at the upper levels of education. In other words, a white woman with any of these degrees and a Black woman with any of these degrees, the disparity in maternal mortality is worse at the educated end than it is at the less educated end. So why, if education says money, education says access to healthcare, education says you are going to have a good doctor, a good midwife, or going to have doula care or something. Education says you know what to do to take care of yourself as far as prenatal care. Then why would it just be based on race that there is this disparity? So I got really interested in this and started thinking about, the health of our nation, the health of Black Americans, who I care deeply about as a former editor of Essence, and long time. I was there for 12 years. And I realized I need to figure this out and I need to put it in a book, because I think many people, and even me, I believe at Essence, my job was to help Black women be healthier. Essence had a subscription base of 1 million people, a readership of 8 million at its height when I was there. And that's like a lot of Black women that I had access to. So I was really into just take better care of yourself and our health outcomes as a race will be better. Now, I still believe that. I still believe in everything we talked about, physical activity, eating right, all the things we report on in the Black Women's Health Study. But I still, now I am looking at this differently. While those things are still important, we have to look at the effect of racism on our bodies, everyday racism, just like that daily racism scale, the daily discrimination scale we just went over, that matters. Those things that happen to us matter and take a toll on our bodies. Our experience in the healthcare system itself is simply not the same. We do not have equal treatment. Even when access is the same, we are not treated as well. And I found that out personally through the experience of my father being mistreated really badly in the healthcare system when he was ill. Even though my mother and I we had to go visit him dressed in, business clothes because we were so afraid of not getting respect just as his visitors. We saw him being treated terribly and restrained to the bed, wearing dirty gown, being yelled at when we went to the hospital. And I'm thinking, even my father, who's a trained scientist, could not get equal treatment in our healthcare system. And then finally, the neighborhoods we live in, Black communities, because of the discrimination, the legacy of segregation, the legacy of discrimination by the government, what we were talking about. I saw that slide. I was really happy that the next level of that study will be not just looking at everyday racism, it'll be looking at state-sanctioned structural and institutional racism, which is a huge barrier to our health in America. And that's what my book is about. It isn't as terrible as it sounds. What I try to do is I'm a storyteller. So I try to mix the statistics and the data and the evidence and the research with the stories of real people that I've met as a journalist, real people in my life, my own life experiences. There's a nice bit about this study of how I got involved. I tell that story and talk about the real work and the importance of it. And also I try to offer solutions. And the solutions, there are solutions out there especially to the discrimination in the healthcare system itself. We have solutions. I think there has been movement in this area. We have seen more, doula care and community health workers really help change our experience as Black people in the healthcare system. And I tried to talk about the importance of those people who put the care back in healthcare. And I'm really impressed with our current crop of medical students who are much more social justice oriented, who are much and not just doctors, students going to be doctors, but people getting their PhDs, people interested in health policies, people studying midwifery, people studying nursing, who are really trying to be better and, be better and do better and change the narrative that we have right now in America. So that's sort of the big picture of my book, but I'm really, really proud to be here. And I think being part of this study is one of the, one of 59,000 really, really important part of my life and my work. So thank you.
Thank you so much, Linda. Thank you for those words. I'm going to turn this over to Dr. Holder, Etienne Holder, for our Q&A. And so I just want to say that I've seen a few hands raised. We can't respond to the hand raised, so please put your question in the Q&A. Okay, thank you. So Etienne.
Hi, hello everyone, and good afternoon, good morning, wherever you're listening and tuning in from. So I just received my PhD, and so I'm a new trainee, very pleased, and it's a pleasure to be here and be working with the Black Women's Health Study. So I'll be moderating our Q&A, and with our presenters, thank you to all of our panelists for those great presentations and speaking about your book, Linda. So please do remember, if you have any additional questions as we go through the question and answer section, to add that to the Q&A feature on Zoom. So we have some frequently asked questions from the registration as well. So thank you for all those questions we received. So to start off, what are some specific exercises to improve memory or cognition? And any of our panelists, please feel free to chime in and answer any of the questions.
Well, I'll start with that one. And I will say this, keep your mind and your body active. And as far as your mind, learn a language, go read, go beyond reading. I think learn a language. There's a free app on the internet that you can use. I've started learning Dutch. It's really fun. Pick up a musical instrument. Pick something up that, maybe you played as a kid or a young person. Try that again. That's extra good because it coordinates your mind and physical movement. Physical activity is really important. That's one of the ones for which the evidence is strongest. You can't lose with physical activity, right? And then harking back to what Yvette was saying about religion, you don't have to be religious, but you have to stay socially engaged, volunteer. If you're in a church, volunteer with the church, keep up with your friends, relatives, take a walk with your friends while you're speaking another language, just keep your mind as active as possible. And I'll just add, none of these is a guarantee. Of course, we have not found any silver bullet, but all of these things will help keep your brain healthier.
So how does sleep impact depression and anxiety?
Well, people who can't sleep get anxious and then it affects their sleep. So anything that can work on alleviating your anxiety, the things that Tricia just mentioned, would really turn out to be good for sleep as well. The other thing to remember about sleep is that the bedroom really is for sleeping, and all of the programs that we looked at that have been successful advise people to use their bedroom for sleeping and do other things like reading or playing games or catching up on your emails. You really should not be doing that in bed. You should be doing that in another room. So bed is for relaxing and then sleeping.
Thank you. So I think this question is for Dr. Sheehy. The question is, so is there no benefit to exercising or working out more than 5 hours?
There are greatly reduced mortality when you work out for more than 5 hours per week. And also, I would like to point out that a study that has been shown that even if you are doing 2 or 3 times higher than the higher bound of guideline recommended level, there's no harm associated to it. So physical activity has shown to be beneficial in many aspects of our body, and also not just reduce to mortality, but with various health outcome, and with make us to have better emotional, better mood, and a good mental health, as well as build a strong sense of community and a greater support of social support. So there's, if you are currently doing more than 5 hours per week, I would say congratulations, that's really wonderful, and just keep doing that.
Wonderful, thank you. So Dr. Kozier, when you were using religion and spirituality interchangeably, or were you concerned or not so concerned with the difference?
So, you know, the way the scales are really sort of set up, it's around to measure religiosity or spirituality. So I was sort of using them interchangeably, but they are, you know, slightly different things. So some people are highly spiritual, but they have no affiliation with religion, and we know people who have religious affiliation who are minimalized on the spiritual side. So they are not interchangeable, but just really for usually just the ease of conversation, I will refer to the two of them together.
And it looks like some participants are interested to know how we decided to send the religiosity and spirituality questionnaire to certain participants.
So we randomly selected. So we had some funding. It was a limited amount of funding, secondary to the National Cancer Institute funding that we work from. So we did not have enough money to mail to all 59,000 women. So we did a random sample to maximize, and I can't entirely remember the number, but it was a few thousand that we mailed to. We would have loved to have shared more, but we were constrained by cost.
See, and one other question, Dr. Kozier. Let's see. What do you think accounts for the BWHS participants' results scoring higher in religiosity and spirituality than the other four countries?
So one thing that we learned in sort of doing that comparative analysis was that in some cultures, you know, certainly where there's high spirituality and how individuals are taught to view a relationship with God, so that the spiritual relationship is a little different than the way that we do so in America, or even within the Black church. So we also have to consider the history of the Black church and how central religion and spirituality was to civic life. And so for our participants within that context, I think the presence of religion was just a bit more present. Now, that's not to say that other groups did not have a great investment or a great cultural investment. It's just sometimes that relationship is framed a little differently.
Great, thank you. And for Linda, there are a few questions that came in during your talk. The first was, why would more education mean higher mortality for Black Americans?
It doesn't mean higher maternal mortality. It means that education doesn't erase maternal mortality. In other words, if this were a problem of just about poverty or just about lack of education, then being more educated, it should be Black women aren't dying in such high rates. And the problem here is that it's the gap. In other words, it's the gap between Black and white women at the same education level, but also that even the more educated women still have high rates compared to lesser educated white women. So it's more like the disparity rather than that it's, you know, like going up, it's higher than lesser educated women. You know what I mean? Lesser educated Black women. So it's still lower among highly educated Black women compared to less educated Black women. But the problem is, why doesn't education and access to healthcare and things like that get rid of this problem?
Great. And does it matter if a Black person goes to a Black or doctor of color for their care?
Yes, a lot of studies have shown that as far as birth outcomes, pain management, and several other kind of health, measurements, Black patients do better with a practitioner or the provider of their same race. However, only 5% of doctors in America are Black, and even it's something like 2% of Black women are Black women. So it's going to be hard to find. Sometimes it can be hard to find a practitioner of our own race. So I think what we need to do is make sure that all doctors, whatever race they are not coming into the system, with some kind of implicit racial bias that they're practicing with. And so, because it's just not enough we just don't have enough Black doctors to meet all of our needs.
Great, thank you. Some questions came in around the sleep services that were presented. So one question asks, when might BWHS assist in getting a Somers program or something similar for insomnia for access without a prescription? And also participants are interested to know where they can get the CBTI treatment.
Could you say that first question again? I didn't quite understand it.
Sure. They're asking when might the study assist in getting one of these like sleep programs or something similar for insomnia, their participants access without a prescription.
Right. It's not possible. The thing is, these programs have to be approved by the Food and Drug Administration, and the only program they have approved that's online is this program called Somrist, which is the same for shut-eye. And that's a commercial company that had to do a lot of legwork and had to spend a lot of money to get to the point where they could get FDA approval. So it's just like getting approval for a drug. It's very expensive. And which is why this program is not so widely dispersed. Some institutions, some medical institutions do have a program available there, but if your institution or your doctor's practice doesn't have it, then you cannot get access to it. So it's very unfortunate, but that happens to be the situation, which is not to say, now there might be a trained CBT person at your medical practice that you go to, or at the hospital you go to. So that's something you could ask about and see if that's available. But the other thing is that if you read some of this material on sleep, it's just very helpful to read it, to learn the things that most people know not to drink caffeinated coffee before they go to sleep. That's going to keep you awake, that kind of thing. And that you should try to relax before going to sleep. But if you read the material, you'll learn other things that you can do, and they're very helpful even without a CBTI program.
Thank you. This next question is about data sharing. So where and how is this data being shared? This data is critical support for policy change and can be used by community and population health initiatives to apply for grants and other funding for programs that can improve health outcomes. For example, Girl Trek and the physical activity data. This information is helpful to my work in health equity and racial disparities education, but it should be shared to empower lay people and policymakers.
So
I'll just say, I'll introduce you, Yvette, to speak to this because you're much more involved in big meetings and that kind of stuff. But everything that we've presented here has been published in medical journals or epidemiology journals, so it's out there. Now, a lot of lay people probably don't know how to access that material, but certainly other scientists and investigators and physicians do know how to access it. So Yvette, why don't you talk about more wider ways to disperse this material?
Sure. So for scientists, for qualified scientists, the process is to one approach us with a proposal, and we review that proposal, and if it's appropriate, if it's not conflicting with what we're doing, we try to accommodate working with other scientists for this information. We also protect your information because we are entrusted with your data, so it's not that easy to simply turn it over to other entities without proper credentials and a pressing need. But so the data sharing, as Dr. Rosenberg said, that the primary way of data sharing is through presenting this information. The American Public Health Association, for example, was just in Boston. I don't think we had any BWHS presentations there, but that is a large body of policy and local health department professionals who come to hear information being disseminated and look for ways to take those findings and turn them into policy, just as the question asker indicated. So it's a very complex way in which data are disseminated, but sharing is something that is tightly held. Our data are tightly held, but we have mechanisms for qualified researchers that we try to accommodate.
Thank you. See, and this can go for all panelists. So is there any consideration or thoughts about including girls in the Black Women's Health Study? My reasoning or thinking is that girls would benefit from early health education with the hope of being a healthier woman going forward.
I can answer this. We thought about this maybe 10 years ago, and we actually surveyed Black women. I don't remember if we wrote to, I think we, yes, we had a question on our, one of the follow-up questionnaires asking, would you be willing, or do you think your children would be willing to be in a study similar to the Black Women's Health Study? And we didn't get a very encouraging response, which is why we never proceeded with it. Also, we got old and tired. So it's probably a very good idea to be following young cohorts of Black individuals. But as long as I have the floor, I just want to thank Linda Villarosa so much for taking time out from a very busy schedule and actually making 10 copies of her book available for to be given at random to BWHS participants. I'm not sure how it's going to happen.
Yes, we do have the book available. Thank you, Linda. And Linda has graciously signed copies of the books, and we have 10 that we can raffle off to our participants.
Yes. Can you put to the next slide at the end?
Yes.
Okay.
Well, thank you all very much for your questions. Sorry we couldn't get to all of them, but they're all very insightful.
Yeah.
The next slide.
There we go. Yeah. Mm-hmm. So
yeah, so 10 books to give away. So thank you, Linda, for that.
Yes. And I just want to swing in and say to thank Etienne, Nora, Maria, Lauren, Carolyn, Renee, Delia, Patricia, and Lisa for all of their work behind the scenes to make this happen. And to thank the participants, because without you, we have nothing to present today. So thank you, and we hope that you will, you have the site here where you can find the recording, and we thank you for your continued support of the study.
I wanted to say thank you for having me. I really appreciate this. I am now leaving to go teach my class of pre-medical students. That's my newest teaching assignment at the CUNY School, City University of New York School of Medicine in Harlem. I'm at my mother's house with the pretty Art, who lives in Harlem. So I'm going to walk there, and I really feel like they, we're talking about doctors of color. They really are the future of medicine. So thank you very, very much. And whoever gets the 10 copies, enjoy the book.
Thank you so much, Linda.
Yes, thank you.
Everyone have a great afternoon and a healthy Thanksgiving holiday next week.